Good morning, everyone. It is my pleasure to introduce our Pediatric Grand Round speaker here at UPMC Children's Hospital of Pittsburgh. Dr. Eyal Cohen co-founded the Complex Care Program in the Division of Pediatric Medicine in 2006 at the Hospital for Sick Children, otherwise known as Sick Kids, in Toronto. And he is currently the program head of the Child Health Evaluative Science in the Research Institute at Sick Kids, and is also the co-director of the Long Center for Healthy Children, which is a newly established research center focused on child health equity. He is a professor of pediatrics and health policy, management, and evaluation at the University of Toronto, with cross appointments at the congenital Center for Childhood Disability at the McMaster's University, and in the Department of Clinical Epidemiology at Aarhus University in Denmark. He is the recipient of numerous honors and awards and is known for his dedication to improving systems of care for all children, but especially for children with medical complexity. He has broad experience within the Canadian system, but also within our own in the United States, having served on many panels and advisory committees for organizations across the nation here, including the Maternal and Child Health Bureau. He recently completed a visiting scholarship year at the Center for Policy Outcomes and Prevention and Clinical Excellence at the Research Center at Stanford University. And on a more personal note, Dr. Cohen and I are good friends and colleagues. After meeting each other years ago at Pediatric Academic Societies, I knew I needed to know this man and learn from his wisdom. So it's an incredible pleasure for me to be able to introduce him to all of you today. And as you recall, you may ask questions into the Q&A, and there'll be questions after this, as well as a meet and greet if you want to talk more with Dr. Cohen. Thank you, Dr. Cohen. I look forward to your presentation.
Thank you, Dr. Houcho. I'm hoping people can see my screen. Aha. Can you see my screen?
Yes.
Okay. Thank you. It's a pleasure to be here today, and it only took 15 seconds to get through the technical difficulties, which are pretty par for the course nowadays. So thank you for allowing me to speak today. I'm going to try to share with you over the next 45 minutes or so some of my thoughts around the emergence of complex care, what it means for our health system, and things we can do better to serve these children and their families. I'll begin with my disclosure, of which I have none, and go through my objectives. So the beginning of the talk, I'll talk a little bit about what one of my mentors, Paul Wise, called the transformation of child health, a little bit about the change in the epidemiology of children, youth, and young adults with complex care needs, and why it's an important issue for us to address as pediatricians and healthcare providers. I'm going to talk a little bit about particular challenges of care delivery that are aimed at populations of children with complex needs from the perspectives not just of the children, but their families, the clinicians in the healthcare system, and end by talking about some tools and programmatic initiatives that I think are important to better serve this population. So I'm going to begin with a little bit of history. And one of the great successes of child health has been the incredible medical, surgical, technological advances that have led to improved survival of just about every condition in childhood. And superimposing onto this line, just to put this in a little bit of perspective, is Bob Dylan's wonderful ballad from 1963, The Times They Are Changing. And I'm going to use that as a bit of a frame of reference, even though it was a long time ago, just to really articulate how incredible these changes have been. So in 1963, Patrick Bouvier Kennedy was born to Jackie Kennedy in Cape Cod. Unfortunately, was born at 34 weeks gestational age with hyaline membrane disease. At the time, there was no ventilation, there was no surfactant. There weren't any of the amazing things that neonatologists do nowadays. And sadly, Patrick Kennedy passed away shortly thereafter, following a transfer to Boston Children's Hospital. This sparked an incredible slew of research that has revolutionized neonatology and continues to this day. But there's a cost to this success. And this graph I like, it's a little bit dated, but really shows, I think, quite starkly what I mean by this. So I call this a good news, good news story. So all this compares is outcomes of children, of infants born with prematurity, extreme prematurity, under a kilo in weight, from the 1980s to the 1990s, just a change of 1 decade. And what you see here is the white is what's called intact survival without any developmental disabilities. The black is death, and the gray bar is survival with impairment, visual impairment, auditory impairments, or intellectual disabilities. And what you see here is that there's been a lot of good news. The white has increased in size, so intact survival has improved, mortality has reduced. But the rate at which mortality has decreased is larger than the rate at which quote unquote intact survival has increased. So as a consequence of that, you see that there's a tripling in the size of this gray bar here, meaning that there are survivors of extreme prematurity who still have significant sequelae associated with their conditions. Another example from not exactly the same year, in August 1963, at my hospital here in Toronto, Myra Willing, the woman in the photograph on the left, had a procedure called the mustard procedure conducted, which was the first time that there had been a surgical repair of transposition of the great arteries, a condition that now has almost normal outcomes. But before that was almost universally fatal. On the right of this diagram, also in 1963, a citizen of Pittsburgh, Thomas Startle, conducted the first liver transplant. And again, a condition that had been previously fatal had nowadays leads to long lifespan. So you see from all of these examples, all just randomly chosen from the same year, this incredible change in survivalhood related to things we do in pediatrics, and that's continued to this day. I do a lot of work in drug policy. I've been recently reviewing some of the new drugs coming out for spinal muscular atrophy, like lots and lots of conditions. Still to this day, we have these incredible scientific revolutions that are allowing us to keep children alive longer than ever before. So as a consequence of that, this graph shows a series of different congenital anomalies: spina bifida, congenital heart disease, Down syndrome. We're seeing this huge rise in life expectancy for a wide variety of childhood conditions. There are now more adults with congenital heart disease, way more adults with Down syndrome than there are children. And really the point I want to make when I show this graph is, even though many of these, these incredible innovations occurred a long time ago, what we're really seeing is, even to this day, this growing in survivorship, which really makes us rethink the kind of care we provide to a lot of these kids, and the needs that they have that we never thought about even 10, 20, 30 years ago. So who are we talking about? When I think about populations of children, most children, fortunately, are healthy, and we create systems of care to keep them that way. And that is primary care. That is a lot of our acute and urgent care. And most of these kids who go into these systems of care come back out and resume their lives without any long-term consequences of, for instance, their visits to our acute care facilities in our organizations. There's a smaller group of children, many of you are familiar with this term, children with special health care needs. This composes about 15% of all of the nation's children. And these are children who have more healthcare needs than the average child. But the group I'm going to focus on in my talk today are the tip of this pyramid, children I'm going to call children with medical complexity. So to take a step back, when I talk about the word complexity, I think it's an important word to define. And sometimes the easiest way to define complexity is to compare it to other terms that are often conflated with the term complexity. And I like to sometimes juxtapose complexity with the term complicated. So lots of things we do in life are complicated, and lots of things in healthcare are complicated. For me, a prototypical example is my smartphone, right? So complicated things in the universe are things that have many components that interact with each other in very intricate ways. But a defining feature of a complicated system is the predictability of those interactions. So if I press the on button on my phone, presuming it's charged, 9,999 times out of 1,000, it will turn on, right? Predictably. So that's like a complicated system. And there are many examples of that in healthcare. You know, if you think about some of the examples I gave before, transplantation, where we can protocolize a lot of the care and develop lots and lots of standards. And by doing that, we can have outcomes with somewhat minimal variability. Complex systems are different. Complex systems are systems, again, lots of components with lots of interactions, but the key to them is that they work in unpredictable ways. So for me, a classic example of that is parenting. I have 3 adolescent children in my home. And in the morning, when they wake up and walk down the stairs and wave hello, and I wave hello to them, usually I get a smile, but sometimes I get a grunt. And there are things I can do to minimize the likelihood that I get a grunt in the morning, make sure they get sleep, make sure I'm nice to them the night before, etc. But even despite all those things, oftentimes things don't happen as predicted. And more and more in healthcare, when we're talking about the kind of patients I'm going to be talking about today, a lot of our care fits under that paradigm, that it's not predictable, that there's a lot of nuance to the relations between different components of care. Complex systems have lots of things associated with them. So this gets to the concept of multiplicity. Children with medical complexity have lots of needs. They have many body systems affected. Many specialists look after them. There are many funders who can be involved in helping support their care. And all of these things are very interrelated. There's also a depth of needs and issues that are associated with complexity. And this gets at issues like disability, functional impairment, a concept termed medical fragility, which I just think of as something that would give me a cold, might make one of my patients end up in the ICU, or the seriousness of the underlying condition. So about a decade ago, a group of us got together and tried to formulate a conceptual definition for children with medical complexity, and we came up with this conceptual framework of what we're exactly talking about. And it really aligns, I think, with some of those core features of complex systems. So starting from the top, using the concept of the definition of children with special healthcare needs, these are children who have more needs than the average child, but they're quite substantial and can have huge impacts on the family. They have chronic conditions, but not just any chronic conditions, but those that are severe and or associated with medical fragility. They use a lot of healthcare resources. And by that, I mean, primarily they need care from lots of different people in lots of different places over time. And they have functional limitations. And quite frequently, many of these patients have a need for technology assistance, a wheelchair, a feeding tube, a tracheostomy, an indwelling central catheter, anything of that sort. I think any one of these domains in isolation is somewhat limited in defining the population, but taking the totality of these 4 things together can be one conceptual way to think through who we're talking about. So we used this definition to try to understand in Ontario how many of these kids there are and what are their service needs. So we estimated in Ontario has a population of 14.5 million, I think just a little bit bigger than Pennsylvania. And they represent about 2/3 of 1% of all children, so very small numbers. But the proportion of healthcare use that they use is quite substantial. So even though they're less than 1% of all children, they count for just under 1/3 of all healthcare spending. And they use care from over the course of 2 years from 13 different physicians, in 6 distinct medical specialties. So we're really getting at that issue of, the multiplicity of things that are needed to care for these children. And when we parsed out in a little more detail subgroups of this, so all this graph does is it subdivides these children into those who have a single complex chronic condition. So think of sickle cell disease as an example. This would be multiple complex chronic conditions. So this would be like congenital heart disease and a congenital renal anomaly and cerebral palsy. And the last group is neurologic impairment. So this would get at children who have complex chronic conditions that are particularly neurologic in nature. When you look at this group and then divide out what their healthcare use is, if they have no technology assistance, the largest utilization of their healthcare is in the acute care system. So hospitalizations being the big chunk of that. The rest of these bars, the red here is home care, the green is outpatient physician care, the purple's drugs, and the little blue one is everything else. But once you add technology, so again, things like a feeding tube, a tracheostomy, a central line, you see A, that the utilization increases dramatically, and B, that actually the place in which they're using the most resources isn't even in the hospital anymore. It's actually within home care, which is not a place we tend to focus too much on in health services research, but is a substantial component of the cost and of care for these kids. So we know when other studies have shown that there's huge risks for children with medical complexity. You wouldn't be surprised they're more likely to end up in the ICU if they're hospitalized. They're more likely to be hospitalized for preventable reasons. When they're discharged home, for those of you who practice hospitalist medicine, they're much more likely to be readmitted. And medical error is more common in this population as well. But I want to focus a little bit on some work that I've been involved in, particularly focused on the impact on families. So if you map out in a very simple way what resources and what the needs of these children are, this is just one example, and you can think of many, many others, I'm sure, from your own clinical practice. They're incredible, and they don't just exist in healthcare, all the different specialists. They exist within the social support system, in the community, in the educational sector as well. And one of the parents who was involved in our program, Ian Brown, wrote a wonderful book that I'd highly recommend called The Boy in the Moon, speaking a little bit about what it's like actually going through the healthcare system with his son. And it's quite extraordinary. In the book, he tells a story of going in our hospital to get an MRI for his son. His son has a condition called cardiofaciocutaneous syndrome. And he went to see the anesthesiologist before the procedure. And of course, the anesthesiologist asked about whether he had had a cardiac workup, and he said that it's in the chart, and the anesthesiologist couldn't find it, and it ended up the procedure was canceled because of that. And at the end of the day, it was dug somewhere deeply in the chart, and that was just missed. And again, it's just one example from this particular book, but listening to families again and again and again, that's their experience navigating through the healthcare system. And to quote Ian Brown, this is what makes grown adults yell at receptionists, right? This is what oftentimes we see these pejorative terms used about families, the difficult family, the angry family. And it really is just a reflection of their experience, their traumas, of going again and again and again through the system, having to tell their stories again and again, and meeting systems that just don't work for them. We've done other work on the impact this can actually have on families. I just want to allude to a bit of it. This is some work from a PhD student of mine, Krista Kelty. She did a really interesting study where she took families of children with technology and gave them actigraphs to measure their sleep, and compared them to age and sex matched controls from a primary care pediatric practice of healthy children. And not surprisingly, I think to anyone attending today, these families were less likely to sleep well, both subjectively and objectively, with an actigraph by any measure of good sleep. So you can imagine just looking at a simple one of these statistics, just looking at total sleep time. If you're sleeping, 45 minutes less on average than another person every single day of your parenthood, you can imagine the impacts that would have on your mental and physical health. And another example of some work we did, this one is just looking at income. So an interesting thing is we know that children with chronic conditions are more likely to come from poorer families. That's well described in the literature. But I've always been fascinated by the question, to what extent is that caused by the fact that families and parents are at higher risk of having a newborn with a complex chronic condition? Or is it going through life and the financial strain of raising a child with a complex chronic condition? So we did this by looking at a birth cohort of babies born with complex chronic conditions and comparing them to healthy newborns. So if you look at the left here, these are just income quintiles. So quintile 1 is the lowest income quintile, quintile 5 is the highest income quintile. So this is a proxy for poverty. And what you see here is the blue bar is birth and the red bar is at age 5 years. And not surprisingly, from birth, parents of children with complex chronic conditions are more likely to be in poverty than healthy children. By the time they reach 5 years of age, both groups kind of traverse up the income ladder, which isn't surprising because young families have often not established their careers. So over time, there is a little bit of movement out of poverty amongst young families. But if you look at the difference between these two groups, there are more families of children who are healthy come out of poverty than those who have complex chronic conditions. So that by the time they're 5 years of age, healthy children are just as likely to be in the lowest income quintile as the highest income quintile. But the disparities amongst families of children with complex chronic conditions widen. So much more likely to have not made it into higher income quintiles. And this, all of these things, the poor sleep, the toxic stress of poverty, all of these things can have an impact on parental well-being. This is some work from Elizabeth Epple and Elizabeth Blackburn. Elizabeth Blackburn won the Nobel Prize, I think, in 2008. She's from UCSF, and she studied telomere activity. So telomeres are the caps on the end of chromosomes that prevent premature cell death, and telomerase is an enzyme that prevents the degradation of telomeres. And what you see here, the blue bars of parents with low stress, and this was actually done on mothers, so mothers with low stress, and the red bars, mothers with high stress, and telomeres were shorter in mothers with high stress and mothers, and telomerase activity was more inhibited in mothers with high stress. So this was a basic science paper published in PNAS that was cited by the Nobel Committee in Dr. Blackburn's awarding of the Nobel Prize in Physiology. But when you dig into the actual paper in Appendix C, where they describe the clinical characteristics of who they actually recruited, she actually recruited mothers of children with medical complexity into her study to assess this. So a lot of biologic plausibility for effects on parent well-being. And then we studied actually this using big population level data sets in Denmark. We looked at children with congenital anomalies because it was an easy way to compare them to matched controls. And we looked over time to look at mortality amongst mothers of children with congenital anomalies. The blue line here is mothers of children with multiple congenital anomalies, so multi-organ congenital anomalies. Again, giving an example, congenital heart disease and congenital renal disease, or brain malformation. And single organ is just one organ being affected. So you see here that there's, even after adjusting for a whole bunch of important confounders, there's about a 21% increased risk of premature mortality amongst mothers of children with single organ major congenital anomalies. And there's a bit of a dose response relationship. So for mothers of children with multi-organ, more severe major congenital anomalies, the risk goes up to a 31% increased risk. And you might ask, is this just true for mothers? We looked recently at fathers, and it's true for fathers as well, although the effect size isn't as large as it is in mothers. So these are similar Kaplan-Meier curves using these data sets, comparing mothers of infants born with and without anomalies and fathers of infants born with and without anomalies. And you'll notice fathers are more likely to have premature mortality. That's just a well-known demographic feature of men. But even amongst fathers, there's an increased risk of mortality if their infant has a major anomaly. And the cause of death that's been described has been mainly premature cardiovascular disease, and we've looked at that. And again, that fits that kind of causal pathway of stress being well known to be associated with cardiometabolic syndromes and being associated with premature mortality. So, at this point of the talk, you're probably thinking, oh my goodness, complex care. It's, for those of you who don't practice this regularly, it's awful. It's like watering a tree that's about to collapse. I'm going to move on to talking about solutions. And before I do, just want to briefly say, as difficult as it sometimes is to think through some of these issues that these children and their families face, it's extraordinarily rewarding to work with them and partner with them in improving care. So I'm going to talk for the next 15, 20 minutes about the program I've been involved with at Sick Kids since I came on as faculty. I came on faculty 15 years ago. And at the time, one of our community pediatricians was trying to push us to begin a program focused in complex care. He had been really frustrated in his primary care practice in looking after these kids because their care was so balkanized and it was so challenging to try to coordinate everything together. So he helped raise some seed funding to catalyze some work that we did. The first thing we did was try to think conceptually around how do you deliver complex care. There's lots of really good conceptual models for chronic disease. I'm sure everyone's familiar with the medical home, family-centered care. I really like this one in particular, and I'll explain in a minute why. This is the chronic care model developed by Ed Wagner and his group at the McCall Center in Seattle. And it focuses on what do we need to best care for people with chronic diseases. And this was originally formulated actually for geriatrics, but is very applicable to pediatrics as well. So the first thing to mention here is the top of this bubble. You cannot do complex care without a healthcare system, right? Like if you're practicing in a low resource income setting, it's very, very challenging. You need a community of care. You need healthcare systems. You need clinical information systems, delivery systems to support that. So that's a given. The second piece, which is the most important piece, is this notion that complex care can only work when you have productive interactions between a proactive practice team, that's us, the healthcare sector, and an informed and activated patient and family. And sometimes I think a little bit about this. The best way to articulate this is, again, by juxtaposing this with something else. So how does chronic care differ from acute care in many ways? So let me give you a scenario. Heaven forbid, in the middle of this presentation, if I presented with retrosternal chest pain and needed to go across the street to the adult hospital that exists in Toronto, across the street from my hospital, and needed to be serviced for an acute coronary syndrome, what would predict my outcomes? My outcomes would be optimized based on a number of things. How timely I receive care, whether the people who are providing care to me provide evidence-based care, whether if I need some technical procedure, I need to go to a cath lab or something like that, whether the cardiologist who's providing that service is technically proficient, right? So all of those things are critical to the outcomes in acute care. Those things are important in chronic care as well. But if I'm looking after, say I'm an endocrinologist, I'm looking after a child with diabetes, I can be, the William Osler of diabetology, the greatest clinician in the world. But if my patient on the other side of me isn't informed and activated and really co-producing care together with me, their diabetes control will always be suboptimal. So that for me is like the secret sauce of complex care. It only really works if you can partner with your patient and their family in the delivery of services. And that's what I really like about this model. So when you apply this to actually what this actually means in the real world, a big piece of the role we have as providers is actually untangling all of that mess of services that sometimes exist in the lives of these families and providing them kind of that single locus of someone who's out there for them and looking after them and working with them together to navigate this system. And in the literature, it's often called a key worker. There's many different terminologies to it, but that one individual can be a primary care physician, it can be a subspecialist, it can be a nurse practitioner, it can be a social worker. Like the disciplinary framework is less relevant because it actually depends on what condition you're talking about and what setting and what context. But the idea that someone takes ownership and is responsible for the care of the child, I think is a critical piece of any complex care service delivery. So when we designed our program in Toronto, that's kind of how we thought about it early on. We began with an inpatient program, and there are many flavors of complex care programs in different centers across North America. Some are inpatient, some are outpatient, some are community-based, some are hospital-based. We began with a very, very inpatient-focused program. We had 6 or 8 beds that we had for the patients who came in and out of hospital recurrently, who met these complex care criteria. And it worked really well. We had a nurse practitioner work together with our hospitalist group to deliver care. The families were happy. The hospital was really happy because we were able to provide more streamlined services to them. But a big issue arose, which was when we discharged them from hospital and we like high-fived them as they were going to the curbside, we worried that fumbles would happen, that when we tried to transfer care back to community settings, it was always challenging. And we'd have lots of readmissions and we'd have dissatisfied families around that aspect of care. So we went back to the drawing board and thought a little bit about this. And it dawned upon us, and lots of people have described this in the past, that we have a little bit of a discordance between where resources exist and what needs are. So there tends to be, most of our healthcare systems have been designed with a fairly hospital-centric focus, where we have more resources in the hospital than we have in the community. And that kind of works in an era like 1963, where most of what we saw in hospital was previously healthy children who came in with, broken limbs or infectious diseases or those sorts of things. But in an era like today, where most of what we see in a children's hospital is actually, particularly on the inpatient side, is chronic disease, then it really dawns on us that we need to think a little bit more about how we can kind of even this discordance in where diseases are and where care exists. So we moved to trying to develop an outpatient program. So we created an ambulatory program. It was a referral-based program in complex care, and we ran it at the Hospital for Sick Children in Toronto. Again, it was a partnership between a nurse practitioner and a hospital-based pediatrician. It was kind of weird because we were hospitalists and we were providing ambulatory care, but we went with it. And during the process of developing that, we worked on trying to develop a number of different tools to try to facilitate care in complex care. And I'm going to allude to a few of them. So one of the things that when I was a resident, I practiced in the last year before we moved to an EMR. It's for the younger people in the audience, that's probably like ancient history. I remember, one of these complex care patients would come to the ED, and it'd be 3 o'clock in the morning. It'd be the 3rd visit they had that week to the emergency department for whatever issue they came in. And I'd go and I'd try to find the chart, and it would be like volume 11 of 12 sitting in the back there. And the only thing I could find in there were like IV infusion orders. And so I'd go and I'd walk in and I'd tap the poor mother who was by the bedside trying to get an hour of sleep, and say, I'm sorry to really bother you, but can you tell me again, does Sally have any allergies? And I was yelled at. And the interesting thing, I think, is even though we've moved to EMRs and somewhat better facilitation of information transfer using that modality, I still hear from families the story that, someone's too lazy to go through notes from way back when to figure out issue X or issue Y related to their child. And parents still tell us that they have to tell their stories over and over again. So a key piece of things that we've done in our program, and many programs in complex care do in other centers as well, as the development of these care plans. So care plan is like a medical passport that summarizes all the child's information, so that if someone's meeting them for the very first time, they can quickly get up to speed about the key things they need to know about the child and the family. We've done some research with families. This is work led by Sherry Adams, who's a nurse practitioner in our program, about the kind of things they like in the care plan. So a couple of things. A huge piece that we found really helpful is this idea of common presenting problems. So saying, this child, if they come in, they don't react really well to this anti-epileptic drug, we recommend you use this one, even though in your normal seizure pathway, that's the drug that you would use. That's an example of one. Sometimes it can actually be an environmental thing. I had a patient a number of years ago who was nonverbal and got very anxious every time she came into the hospital, but the color purple and purple blankets somehow always calmed her down. So we put that in her care plan. Another really critical thing that families have taught us is actually inserting a photograph. I actually believe we should be doing this routinely for patients. And in complex care, it's actually even more helpful. It does a lot of things. It humanizes care. You have a face. It lets you see a picture of what the child looks like when they're well. Like a common question we ask when we meet these kids for the first time is, how are they relative to their baseline? This gives you a little bit of a clue of that, and very simple and thing to do. And the third thing is putting in overviews that emphasize positive things about the child. A common question I ask when I meet a family for the first time is, tell me what makes you most proud about your child. Tell me what your child loves. And again, puts a face to the child so that they're not just a series of medical information. Another tool we started to use, it doesn't work with all families, but is really, really powerful, is the concept of a care map. A care map is essentially a communication and an artistic tool. What it is we ask families to draw a picture of who they are and the connectivity they have to other people. Some families draw very medical diagrams like this. Some families draw things that look very different than that. And again, it's a one pager, and again, if you're meeting this child, Kate, in this particular example for the very first time, you take a step back and you don't jump in and say, remind me again, does Kate have any allergies to any medications? It really forces us to kind of be like, oh gosh, this family's going through a lot, and we really need to think a little bit about, which elements of this are really entangled and we really need to untangle when we interact with them clinically. And we have now been pushing these concepts to try to build technological solutions that we can now ingrain into our EMR. We have a really nice project that my colleague Julia Orkin's leading with a startup called NextJ that's trying to develop handheld tech solutions, mobile tech solutions that incorporate some of these things. So just 3 examples here. This is a care map that one can create on a mobile device pretty simply. A symptom tracker, really, really helpful for particular conditions like seizures or fevers or those sorts of things that can be personalized for each individual family's needs, and it can be a wonderful communication tool, and also direct messaging for communication with clinicians. So we're building these prototypes, and they're going to try to work with our EMR vendor eventually to build these and integrate them into our own EMR so that we can use more of these mobile solutions to again have families engaged, proactive, participating in the collection and organization of information around their child. So I talked a little bit about these ambulatory clinic models. I just want to get into some of the evaluation we did of it. So we tried to evaluate our clinic after we recruited our first 80 patients, and we built our evaluation around the Triple Aim framework of better outcomes, lower cost, improved patient experience. And on the whole, we're really, really happy. We published some of this work. I'm not going to present it today, showing that this was a successful model of care delivery. But there's a 4th arm to the Triple Aim, and that's the Quadruple Aim, which is that another critical important aim in healthcare delivery is improving the clinician's experience. So we surveyed, our model of care was a consulting model, so families were referred to us, but they still maintained a relationship with a primary care provider. And we have to do that because our hospital has a geographic catchment that extends hundreds of miles away. So it wouldn't make sense for families to come all the way to our hospital to get their immunizations, to give an example. And when we surveyed their PCPs, most were really happy with the clinic. They said they'd refer more patients to our clinic if it was available. And it made them more comfortable looking after complex care patients. So we were pretty happy with that. But one thing really bothered us, which was over 1 in 5 of these PCPs said, it's all good and nice that you're running this clinic, but why are you doing my job? Why are you duplicating services that really are that really are something the medical home should be providing? So we thought long and hard about that and worked to build upon our model of care and move to the next step, which has been really exciting, which is developing community-based collaborations. Most are in community hospitals, but some are actually in offices, where we've collaborated as a tertiary care center together with these community sites to provide holistic comprehensive care. And a couple of key principles that are built into this model of care. Shared care, it's not your patient or my patient, it's our patients. We share them together. We build these electronic care plans that I alluded to before. We use these system navigators. So the way we've designed it is we have nurse practitioners from Sick Kids go out and run these clinics once a week in these community satellite clinics. We have a multidisciplinary team. As much as possible, we try to draw resources from the community, but sometimes if it's a specialty dietetic issue, we'll utilize a clinician at Sick Kids, but they come less frequently to care at Sick Kids because they're able to do most of this in the community. We've been using virtual care for a long time as well to try to facilitate that, and we try to emphasize optimal continuity of care. When we evaluated this, we found that kids were less likely to be hospitalized, and if they were going to be hospitalized, they actually were now being hospitalized in the community much more than in tertiary care, which is great because a huge piece of what we're trying to do is actually empower community providers. And families love it. And I'm not going to, I'll just leave this quote up, but I'm not going to read it just in the interest of time. To just say that for families, this is critical because the key piece this did for a place like ours that serves a large catchment area is avoided families having to come unnecessarily for care at the hospital for sick children, which I think is really important. And now we've built upon that and are working towards expanding that to a model of care that would work across the entire province of Ontario. And it's something called Complex Care for Kids Ontario. And our key outcomes are to improving the experience of these children and family and their outcomes, to improve collaboration, communication, and to improve efficiency, effectiveness, and sustainability. Our inclusion criteria are pretty similar. They're we've raised the bar a little higher to ensure that we don't have an overloading of patients right away, but they're pretty similar to the definitions I presented before of children with medical complexity. We now have about 700 kids who are followed at our satellite clinics, which are all these green circles associated with Sick Kids. There are also 3 other children's hospitals, one in Ottawa, one in Hamilton, and one in London, Ontario, that have also come on board, and they've developed their own satellite clinics. We've also reached rural areas in Northern Ontario, which are like 200-300 miles away from the city, to try to build upon this. So our goal is to continue to expand this and eventually have every child with medical complexity who can reach some sort of an integrated program within 60 miles of their home. And hopefully we'll be able to reach that goal over the next 5 to 10 years. We're in the midst of completing an evaluation of this, which we've run as a waitlist randomized control trial. So everyone receives services, but because we couldn't roll this up immediately to everyone right away, we took advantage of that to have to randomize a waitlist versus being seen earlier, and are completing that evaluation. An interesting piece of the evaluation is we actually partnered with families and providers to develop the outcome metrics. So families told us what mattered the most to them. And interestingly, we're actually measuring parent health outcomes as well. That came directly from the families as one of the outcome metrics for the evaluation of this initiative. And parent well-being is a huge piece of what we're now focused on as a program. We are recognizing more and more that healthy parents are critical to the well-being of the children we serve. Also from my own reflections on my own research, it's actually an important outcome in and of itself. These are people who deserve to have a good quality of life for their own reasons, not just because I'm a pediatrician and care about their children. So just an example of work we're doing in this space. We have another trial we're running focused on kids at risk of entering the complex care program, but aren't actually there yet. And these are graduates of our NICU, extremely premature babies, babies born with congenital anomalies, babies with HIE who undergo cooling, those sorts of examples of patients. And it's a combination of care coordination and some mindfulness training. We have noticed over the years that a huge issue in complex care is that many families undergo post-traumatic stress or chronic stress from things that they've experienced early in their child's life. And mindfulness therapy using this approach, which has been well validated in other populations, called acceptance and commitment training, can play a role in that. So we're running that across 7 children's hospitals across Canada. And again, we'll have results of that coming up in the next 6 months or so. And last but not least, we're also working to build upon a community of practice in complex care. Complex care is not a subspecialty. There are many people from all sorts of different backgrounds who are engaged in complex care, hospitalists, primary care providers, people from PRNM like Dr. Houtro, who are interested in complex care, and lots of great examples of ways of building networks. One we're very involved in is Project ECHO, which is this telehealth initiative focused on creating a telecommunication community of practice where we discuss cases amongst clinicians in lots of different sites and share our learnings together. Amy and I are both involved in another collaborative community of practice called the Collaborative Improvement and Innovation Network to Advance Care for Children with Medical Complexity, which is 10 states that have taken on initiatives in complex care with lots of important partners like Family Voices, HRSA, the AAP, et cetera, involved in that. Kind of developing this groundswell of interest and collaboration to build complex care, rather than going top down and saying, we're going to create this initiative and there'll be some funding for it. These initiatives are usually with not a lot of funding, and just getting people to work together and thinking through how to better care for these kids within their individual context. I can't speak about complex care in 2021 without talking about the pandemic. So if you'll allow me, I'm just going to end by reflecting on a few things related to the pandemic and the care of children with medical complexity. So I think it won't surprise anybody that the pandemic has been very awful to our children and families. It's been awful to everybody, but certainly children with medical complexity have been very much affected. They have had changes to their health delivery systems, challenges accessing care, particularly in homes and obviously school settings, concerns about the health and well-being of their caregivers, home care providers, and limited access to lots of different things. And it's been really, really challenging for our families. And I'm not going to deny that. Hopefully we are at the tail end of the pandemic. I always think about this great quote by Winston Churchill: never let a good crisis go to waste. And I'd like to reflect a little bit about things we can learn from the pandemic that hopefully will continue some of these initiatives to improve care for children with medical complexity and their family. The first one I want to point is infectious diseases. So as I'm sure everyone is aware, influenza has virtually disappeared. RSV has virtually disappeared. There's actually been a new spike in RSV I've read recently in Western Australia, so it's certainly coming back. But it disappeared, and the likely reason why is it's related, at least in part, to some of these non-pharmacologic interventions that have been instituted as public health measures to deal with a pandemic. We tend to sometimes forget how awful some of these other viral illnesses have been to children with medical complexity. Children with medical complexity are at high risk of having severe consequences of influenza, RSV, just about any virus, including the novel coronavirus. I have had patients pass away from influenza during my career. So one thing to reflect on is, what is it that has happened during the pandemic that made these other infectious diseases go away, and what can we do in the future to continue some of that momentum to prevent that? Now, I'm not suggesting we're going to be treating each other as biohazards for the rest of our lives, but certainly, not having people go to school sick, perhaps masking in wintertime around these medically fragile children and other sorts of these successful NPIs, I think are really important. I've had patients who in previous years told me they don't send their kids to school in the winter. Maybe we can learn a little bit from the pandemic. There are things we can do to help protect these really vulnerable kids from infectious diseases. And the second thing is virtual care. I was reflecting with Dr. Houtro before the session on our experiences with virtual care. Certainly, it's a new world. We're seeing lots more of it during the pandemic, and I'm hoping, and I think realistically, we'll continue to see it even after the pandemic. Virtual care is not perfect. It can be challenging. You can't examine patients. Some of the interactions and relationships you develop with families can be a little bit more challenging, particularly when you're meeting them for the first time. But virtual care is here to stay. And I think on the whole has lots of potentials, particularly if we continue to work on how to do it better, how to make it more family-centered, how to incorporate ways of measuring things with wearables or other technologies, so we can continue to get rich information in virtual care settings. And I used to do this thing with my residents when I did resident teaching, is I'd ask them to try to prepare for what it's like taking a child with medical complexity to a medical appointment. What is all the equipment you need to bring? Like actually it's traumatic for many of these families that come and see us. This is really fun. I actually recommend you guys do something similar with your own trainees, because it's amazing how many things they end up forgetting, right? Because there's such a long list, and how challenging it can sometimes be to transport all these things. So I would hope that as we come out of the pandemic, we'll continue to build upon these virtual care solutions that really are more family-centered, so that we can keep these kids healthy in their communities, going to school as much as possible. So on that note, I just wanted to thank you all for taking the time to listen to me today. I'm going to just summarize by saying, I hope from this lecture, I've articulated that these kids they're not a lot of them, but their impact is huge, particularly in child health systems. Their impact is growing, and there are things we can do that can be extraordinarily beneficial to these children, their families, and the healthcare system when we think about how we best integrate care, when we think about how we can best partner with families in the delivery of care. So this is my email if you have any questions. I'm not a great Twitterer, but I do a bit of it. I'm happy to connect with you via either of those media. And lastly, huge thanks to lots of different people who had a role in everything I said today. Thank you.
Well, thank you, Dr. Cohen. That was really wonderful. There are a couple of questions in the chat, and I'm hoping that we have a little bit of time before we wrap up and move to our meet and greet that you can address them. They're from Dr. Justin Yu, who's also in the field of complex care as a pediatrician and also a palliative care physician, who wanted to learn about the level of investment you are getting institutionally.
So it's interesting. I practice in a bit of a different healthcare system than the US, so we have a single payer. When we started our program, we got so I presented 15 years of our history. When we started the program, we had $100,000 to pay for a nurse practitioner. We made a business case. We showed a return on investment. We got a little more investment. And then hit some walls once we started to push for things like social work, community supports, because part of the challenge with when you think about complex care it's all complex care payment, it's all about the perspective of the payer. So if your payer is a hospital and you keep patients out of hospital, they're very happy about that. But things you do to improve quality of life of the patient in the community-based setting, a little less of an interest in. So the second stage of our program, when I described some of these community partnerships, we got some seed funding from our community partners, and we basically went one for one, dollar for dollar together. And the program, despite the data that I showed, still was on stilts after a short period of time because it was financially really, really challenging. Then we got lucky. We made a business case to our payer, which is the government, the Ministry of Health in Ontario. It's one of the benefits of working in a single payer system. and they funded $7 million for what I described for the provincial program that now serves 600 children. So that's now, our costs are $7 million plus physician billing, and that pays for the cost of the provincial program. It's not enough. We still estimate that there's about 2/3 of children in Ontario would meet criteria for our program and don't get services at the moment. And there are parts of the province where there are deserts, there's no program. And we'd like to continue to push for expansion of that. Unfortunately, COVID isn't an easy time to do that because of the financial strain of the pandemic, but we're hoping that if we can show benefit from our trial that we will be able to expand. So that's kind of the dollar figure we're looking at for a population in a province like Ontario. I would say roughly $15 million to run programs like this.
Great. There is a somewhat related question, and maybe some of the data from other clinics around the country in the United States might be helpful here about the cost benefit and where you might see savings, but where you might also see increases in cost.
Yeah, so excellent question. So there's been quite a few randomized controlled trials that have come out, and they're actually quite mixed. Some have shown enormous cost savings. There's some work from Ricardo Mascara in Houston at Baylor, where they've shown tremendous cost savings in their complex care programs. But other studies have been more mixed, including some large collaboratives that I think were funded by the innovation grants from CMS that came out under the Obama administration. And part of the problem is, I think, again, it's around the perspective and what patients are you recruiting. So the paper by Mascara that I'm alluding to, they recruited mainly patients with respiratory technology who are in and out of hospital with a lot of those sorts of features. So children with tracheostomies, who have a lot of pulmonological kind of flavor to them. And that group, that's their really, really medical fragile. So these sorts of initiatives, if you can keep a patient out of an ICU 1 day a year, you've already recuperated way more than the cost of a program. The challenge becomes when you try to expand this to groups of kids who aren't necessarily being admitted all the time to hospital, but their families are drowning. Their kids have tons of issues, mental health, behavioral, medical. You're thinking around like the phenotype of a child with lots of neurodevelopmental disabilities. So that population, it's not acute care that's driving their resource utilization. It's actually community services. And the paradox is you actually have to put more money in to try to sort their lives together. So I actually think it's a bit of a false hope to say complex care saves the system money. I find that actually not a helpful argument, A, because I'm not sure it's true, and B, because I think it takes away from the rights of these children and their families. No one would ever say, we don't make those arguments for other aspects of healthcare. We don't say we're not going to administer chemotherapy to a child with cancer because it costs a lot of money. We do it because we know it's in the best interest of the child. So I think that these economic considerations, while they're critical, I understand the perspectives of payers. I think putting all our money on the fact that we think complex care programs are going to save the healthcare system money isn't necessarily a winning argument in and of itself. For me, it's always been around we want to have impacts on these child's lives and the lives of their families so that they can do things that they're supposed to do as children and so that their parents can cope and function as well.
Great. I think we have time for one more question. I'm going to combine two of them, which is around the care plan and how it gets used and who updates it, and then how that might help in the emergency department, where it takes a lot of time to really dig into a family's history.
Yeah, so excellent question. So the care plans we've developed in their original iterations have been developed solely by the healthcare providers, usually the nurse practitioner in our program. Sometimes subspecialists will put input into it, so we'll send them out to other people to say, okay, here it's a metabolic patient with a very complex dietetic plan. Can you input if this makes sense? We then send them out to families to give feedback and update them based on that. There's some really interesting work going on at Seattle Children's Hospital on developing care plans parents actually inputting into them and us proofreading them, as opposed to them all being from the healthcare provider. That's A, for efficiency, and B, it's actually probably the most accurate way of doing it. And C, if you come back to the point I made before about the chronic care model, it empowers and activates families in the care of children. So I think the short answer is right now mainly healthcare providers, but I think over time we're going to start rolling out platforms to utilize the skills and expertise of families to develop them as well. And then the really nice thing about care plans as they're designed in EMRs, and we use Epic, I don't know what you use in Pittsburgh, but you can actually have different outputs that look very differently depending on the end user. So our care plans, for a really complicated scenario would be pages long, right? We have some that are 6-8 pages long. If someone's seeing a patient in an ED, I don't think they want to read a 6 to 8 page note. So we've been able to work with our partners in the ED here in Toronto that what shows up in Epic is a very abridged version of that. Literally, what are the issues? What are the medications? Who are the providers? That's what they wanted to know, and they wanted the emergency plans. That's all they wanted to see. So the output can look very differently to the input. And similarly, if you send a care plan to a kid in a school, they probably don't care too much about what we care about in an acute care setting. So the beauty of these platforms is you have one source of input, but then the output looks very differently depending on the setting in which the child presents in.
So I'm going to wrap us all up and say a huge thank you for that really informative talk. And I really hope people will join us in the meet and greet, because there were more questions. And I think that we will learn more about program building and opportunities to really improve care for children with medical complexity and their families. So please join us. The link is in the chat to get to the Q&A. Thank you.